Now, this is kind of, things happen sometimes but fortuitously in life. The reason I developed this lecture originally was for the seniors and junior residents, junior students that are in the school, that were already in clinical. And I wasn't teaching pharmacology at that point, so it's like, I need to teach something here that I think people are having a lot of questions about in clinical. So this is what the lecture was for that. But I can put this pretty much in this course now, and I think it's kind of helpful to you. So now you can understand a little bit how we actually monitor neuromuscular blockers during the case. And I'm going to try to go over a little bit about some of the depolarizing agents versus non-depolarizing agents, and now talk about reversal again. So all the last 3 lectures or 4 lectures that we've had is going to sort of be tied into this discussion. Okay? We're going to basically review the actions of the neuromuscular blockers. We're going to assess if the muscle is adequately relaxed. How does the train of 4, tetanus, and DBF work, which is also DBS, which is double burst stimulation. How do reversal agents work? Controversy over reversal agents. When or how should you reverse patients? Remember, that's a question that was asked today. It's a pretty common question. How do you assess reversal, and how do you know you're in trouble, and what do you do? Now, this is a beautiful picture. This shows you the actual alpha motor neurons coming in, and individually, each muscle is activated by this alpha motor neuron. Okay? You literally have to have a receptor junction site for every single skeletal muscle to contract. It's different than the myocardium. Okay, so when we start giving agents, we are basically selectively inhibiting the neurotransmission at these sites. So these are the important sites that we're looking at as actually for the drugs that we're talking about right now. Okay? 99% of people that you're going to take care of, that's where your drug is going to work at. Okay? Now, you can see it's actually located in a very small area of the whole muscle. Okay? So the actual neuromuscular junction site is a very small portion of the total surface area of the actual muscle. The number of receptors that you have are totally concentrated in just this area. And that's it. The rest of the surface area is free of receptors under normal conditions. If you have any kind of denervation injury, any kind, burns, because burns will cause denervation injuries, central nervous system injuries such as spinal cord injuries, you cut a nerve in somebody, you crush somebody, anything that causes that nerve signal not to be transmitted, what immediately happens is that the muscle itself will produce receptors now all over the muscle. So you went from just a little surface area, now you've covered this muscle and now receptors. And that's where you get burned with depolarizing agents. That's how you get hyperkalemic arrest. Okay, these are called the extrajunctional receptors. Also, they're called neonatal receptors, which is what I call them. That's what I was trained to think about them. Okay? Remember your neuromuscular junction site? You have your axon terminals. It gets to your acetylcholine receptors, acetylcholine neurotransmitters, which comes out of the vacuoles, which then bombards the acetylcholine nicotinic receptors, which then causes sodium channels to open after 2 acetylcholine molecules bind and allows sodium to rapidly transfer in, which then sends the electrical potential downstream and eventually causes calcium to be released inside the muscle, which initiates the contraction. And then what terminates the contraction is the repolarization of the cell and the closure of voltage-gated calcium channels and reuptake of calcium. So calcium initiates and ends the contraction, but what actually initiates the release of calcium is the depolarization by these fast-acting sodium channels that are activated by acetylcholine binding. Now, your acetylcholine receptor is made up of 5 protein subunits. There's 2 alphas. That's where the actual acetylcholine binds. For the acetylcholine to actually have activity, it must bind to 2 sites. If it only binds to one of the alpha subunits, no effect occurs. So you have to have 2 acetylcholine molecules bind to one receptor to get activity. Now, one of the things that we have is succinylcholine mimics the action of acetylcholine. It's actually succinylcholine is 2 acetylcholine molecules bound back to back. Now, one of the things that people have asked me in the past is, what about this receptor? Does it have just a single pore? The answer is no. It has two gates inside of it. It has an upper gate, which is close to the surface of the cell, and you have an inner gate, which is closer down here. And what happens when you depolarize the cell, in other words, when you get two bindings, both gates open initially, but the bottom gate closes even though it stays bound to acetylcholine. So it's time dependent. Once the voltage hits depolarization, the lower gate closes. So it limits the duration without the acetylcholine even coming off at that point. The acetylcholine is still bound, but there's no more sodium transfer. So it only stays for a certain duration. So when we say that an agent is a depolarizing agent like succinylcholine, the muscle does not stay depolarized. The muscle is now flaccid because the bottom gate's closed, but the top gate is not. The top gate's still open, but sodium can't get into the cell. So the cell is going to repolarize itself, but it cannot be reactivated until the acetylcholine blocker that you have up top is going to come off, which is in this case succinylcholine. So you also have your voltage-gated calcium channels, which are critical not only pre, but also postsynaptically. Postsynaptically is what I just told you, where you get calcium entrance into the cell, which causes contraction. But pre is also important. The presynaptic receptors that we talk about are voltage-gated calcium channels that are actually affected by acetylcholine. Acetylcholine will bind to this voltage-gated calcium channel and inhibit it. And it can actually be inhibitory. Normally, the voltage-gated calcium channel in the presynaptic site opens during changes in electrical activity of that cell. When your neuron fires and sends electrical activity and becomes depolarized, well, the voltage-gated channel opens. Okay, so, and that should be, because then once it opens, the calcium influxes into the pre-junctional site, and then it causes the vacuoles to be ratcheted out and release the acetylcholine. Okay? So if you can knock these guys out, what does that mean? Well, if you can't let these guys work, then calcium can't go in the prejunctional site, and you won't release any more acetylcholine. And that'll cause you to paralyze. Okay, so that's a prejunctional paralysis. Okay? Now, the presynaptic acetylcholine receptors lead to presynaptic activation leads to a decrease in acetylcholine release, which I was just telling you about. Modulation, this is the modulating site to inhibit excessive release of acetylcholine at the neuromuscular junction. This is a feedback mechanism to shut down the system. Now, the other thing that can also happen is that neuromuscular blocking agents act as two ways. They mostly will bind to post-junctional nicotinic acetylcholine receptors. That's where they want to bind to. But if you give excessive amounts of it, okay, or enough of it, you will start binding to the voltage-gated pre-junctional sites. Okay? And as a consequence, you will get paralysis from that as well. Okay, so it does it in two ways. Acetylcholinesterase, of course, as we just talked about, I showed you this previous picture of how the acetylcholinesterase enzyme breaks the acetylcholine down and it's reuptaken as choline and acetate. Choline is usually the main culprit that comes back in. The acetate usually goes downstream and gets broken down in the bloodstream. Okay? But the acetylcholinesterase is basically going to break down the acetylcholine so you get rapid reversal of the effects of acetylcholine on that receptor. Okay, so this is a nice, this whole pathway showing you the whole thing. I've shown you this multiple times. I'm sure you already know it by now. You're saying, geez, Dr. No, I know this by heart now. I don't need to look at it anymore, so we'll move on. Your plasma cholinesterase is actually an enzyme that's found in the blood inside the plasma, also known as pseudocholinesterase, also known as AKA as plasma cholinesterase. It's also known as butyrylcholinesterase or acylcholine, acyl hydrolase. Okay? So, you know, if you're a chemist, it drives you nuts when you see this kind of stuff because it's got three names for the same thing. But that's what you have to live with sometimes. And it's produced in the liver. The half-time is usually fairly long. It's 8 to 16 hours. And it breaks down butyrylcholine more rapidly than anything else. That's why it's named butyrylcholinesterase. It's also, you have RBC cholinesterases, also known as erythrocyte cholinesterase or acetylcholine acetylhydrolase, and it breaks down acetylcholine more rapidly. It functions to break down acetylcholine to acetic acid and choline in the plasma, which is what you don't want to have. You don't want to have free-floating acetylcholine in your bloodstream. It is not a good idea, okay, because it can go to nerves, it can go to muscles, and cause problems. So you want to have systems in your body to shut this down. And that's what the purpose of that is these enzymes that are found in the plasma. Normally, this metabolizes things that would not normally be in your bloodstream, which is like things like succinylcholine. So succinylcholine is one of those molecules that you must have adequate amounts of acetylcholinesterase on board to really be breaking it down. Okay? If you don't have it, then you start getting problems in the sense that you get excessive duration of action of these agents. Okay, so you have your dibutane number, which indicates to you dibutane number is a local anesthetic that will antagonize the normal activity. If you look at the normal homozygote, it actually antagonizes the acetylcholinesterase activity by almost 80%. The heterozygous, on the other hand, is more resistant to it, so the dibutane number actually decreases in activity. So you'll see it around 55 to 70%, which is around 60. And the abnormal homozygote is down to 20% function, and which indicates to you when you give succinylcholine to that individual, you can have a prolonged duration of action of 4 to 6 to 8 hours, versus the heterozygote usually will increase the duration of action in about 45 to 50 minutes. Now, the neuromuscular blocking agents bind and inhibit the postsynaptic nicotinic acetylcholine receptors at the neuromuscular junction. They bind to activate the acetylcholine receptors, and they also are questionable when bind and inhibit the presynaptic calcium channels. The bad thing about these agents is they have no sedative, no analgesic properties at all. So they really have to be used in conjunction with sedatives and analgesics. Indications, we've already gone through that, so I'm going to pass through this. I already showed this before. Complications is that you can get prolonged neuromuscular weakness. You can get increased risk of developing DVTs, because even when your muscles don't appear to be contracting, they're constantly contracting and increasing venous return flow. So one of the things that we always do when we put somebody to sleep under general anesthesia is that everybody gets stockings with compression boots, okay, just to prevent this problem. Pressure sores may occur, of course, happen because you can't move. Nerve compression injury can also occur. Atrophy, corneal ulcerations, and undiagnosed pain and anxiety, of course, can be an issue. So the neuromuscular blockers can be broken down into depolarizing or non-depolarizing agents. The depolarizing agent, which is succinylcholine, acts as a two-type drugs, either as a phase 1 or a phase 2 agent. The phase 1 is considered a non-competitive agent, and phase 2 acts as a competitive. Your non-depolarizing agents can be broken down into two family groups, which is the benzoisoquinolones and the aminosteroidals. Depolarizing agents, the first one we're going to talk about. I thought it was a cute thing. It says they shot this animal, which is a woolly mammoth. And so this is a great drug. Hey, boy, that new sleeping drug really works fast. Unfortunately, rapid onset and short duration, that sucks. What are we going to name it now? Succinylcholine. Okay? So this is succinylcholine in ancient times. Succinylcholine, the complications with it is severe bradycardia and arrhythmia on secondary dosing, hyperkalemic cardiac arrest, malignant hyperthermia, and muscular pain. Succinylcholine is basically two acetylcholine molecules bound together. If you look at the actual connection points, there's 8 carbons between the two acetylcholine molecules. Okay? It's a pretty impressive drug in the sense that it's been around for almost 70 years, 80 years, and still they can't get rid of it, even though it's all these nasty side effects. But it has its place. 80 to 90% of its metabolism by plasma cholinesterase prior to reaching this receptor. So basically this drug is being grossly overdosed in an individual, but the reason you don't see the gross overdose is because the plasma cholinesterases are so effective in breaking this molecule down. Binds preferentially to the postsynaptic nicotinic acetylcholine receptors most of the time, and it binds to it just like the acetylcholine molecule using the ammonium group. Okay? It does not get broken down by acetylcholinesterase. That's one thing it does not. It cannot be broken down by acetylcholinesterase because it doesn't fit. And myotonic patients won't relax with this drug, and that's one thing that you have to be concerned with. Now, how does the succinylcholine bind? Normally, acetylcholine binds to each individual site. Now, this is a picture way of looking at it. When succinylcholine is injected, 80 to 90% is broken down in the plasma. Then 20% eventually reaches the neuromuscular junction site. And what it does, it comes down and does this. It binds directly onto the acetylcholine sites. And now it stays there. Okay? And once it binds there, it causes this opening of channel of this to take place. Okay, so it depolarizes the cell. What happens next is that in a few moments, the voltage gate in the bottom will close, and then the cell will repolarize, but still will maintain paralysis because the succinylcholine is still bound to the two acetylcholine sites, and it maintains the upper gate in still an open position. Okay? So the depolarizing blocker is open on top, but the bottom one is already closed. Okay? The non-depolarizer agents basically don't allow this channel to open at all. They just block the site so acetylcholine can't bind to. That's called a competitive inhibition. Now let's talk about phase 1 mechanism and talk about train of 4. Okay? If you look at depolarization block, what does that exactly mean? It means that you're basically acting just like acetylcholine. So depolarization is a mimicking effect of acetylcholine binding. But it's not like somebody who normally has volitional control. If you ask your muscle to move, you see it's controlled, nice gradual contraction. When you give succinylcholine, it depends on where the blood is getting to that muscle for it to bind to that receptor site. So you get this erratic contraction that's taking place. You will see actually that what will happen is that the blood supply will really be very important to carry that product to the muscle groups. The ones that have the highest richest muscle group will get the fastest onset of action, versus the ones that have the lowest blood supply, or actually it takes more time to get to their blood supply, then the slower the onset will take place. Fast muscles get affected much faster because they have more blood supply. Big muscle groups which have, yes, they do have blood supply, but they tend to be a little bit more delayed. Their onset of action is more delayed. And actually the most resistant of all of them is the diaphragm. Okay, so the diaphragm is actually very resistant to paralysis. Okay. The other thing you'll see is prejunctional action of succinylcholine stimulates acetylcholine receptors, causing repetitive firing. Recovery from phase 1 block occurs as succinylcholine diffuses away, because there's nothing to break the succinylcholine down. It has to diffuse away, and then it goes down its concentration gradient back out to the bloodstream, where now hopefully the acetylcholine just broke down even more stuff. So now it goes down the concentration gradient and it comes out, and eventually then it gets metabolized with plasma cholinesterase, or also known as pseudocholinesterase. Now, what you see is it binds to the acetylcholine receptor. It's considered non-competitive. The number of receptor blocks will actually lead to different effects, and leads to failure of acetylcholine to bind to receptor. Okay, so now let's look at the actual mechanism. Okay? Now, let me just stop before I start here. What I'm going to show you in the bottom of this picture is the actual electrical stimulus. It's going to be in a green box. When we do a train of 4, we're basically causing 4 stimuli of electricity to be put on the person's skin. Okay? And what we're doing is we're doing it next to the nerve. So the purpose of a nerve stimulator is not to stimulate the muscle directly. It's to cause a nerve stimulation. So you want to put it over the ulnar nerve here, or you want to be over the orbicularis, which is a part of the trigeminal nerve. Okay? So you want to you put electricity, which causes the nerve to fire by depolarizing it. Okay? You're causing the nerve to basically send an electrical signal downstream, which then it releases acetylcholine molecules, just like if you were to tell your muscle to contract. Okay, so we're mimicking the action. We're actually stealing away normal activity, and we're actually putting electrical activity on your skin to cause that effect. Okay? Now, what we are doing is we're giving 4 equal amounts of stimuli every time with the same duration of length. So the height, the amplitude, and the width of the stimulus are the same with train of 4. Just bang, 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 bang. What normally should happen is you should have equal contractions each time. Okay? Each one should be just as strong as the next. That short duration between the stimuli, the acetylcholinesterase is so fast that it breaks down all the acetylcholine, the cell repolarizes and is ready to go again at the same twitch height. There will be no fade. Okay, so under normal circumstances, this is a normal individual. You should see this. Okay, I give the electrical stimulus. I send out 4 quanta of acetylcholine. The next one, same stimulus, same quanta of 4. Same. Now you get a contraction. It's the same height. So, because what you're doing is every time you're giving the same amount of electrical activity, you produce the same amount of quanta release of acetylcholine. So you should see the same twitch height every time. So every muscle contraction should be the same as the one prior. Does that make sense? Is that more visual for you? Okay? Now, let's go now to post-tetanic potentiation. Okay? Post-tetanic potentiation is when I give a long period of tetanus, which means I'm giving the nerve a long period of time to release large amounts of acetylcholine into the site. Okay? So much so that the acetylcholinesterase cannot keep up. It cannot break down the acetylcholine fast enough. So what's going to happen in this individual is you're going to see that the initial twitch height is going to be the same, but when I then I do a train of 4 after the tetanus, I'm going to see an accentuated response. The reason the accentuated response is because I'm going to have residual acetylcholine now sitting in the actual junction. And as a consequence, you're going to get a hyperstimulated response, or you're just going to an elevated train of 4. So here's what you see. The first one you do is tetanus. And when you get tetanus like this, you release not 4, but 7 molecules out. And now you get your train of 4. Look what happened. You got a very potentiated effect. And the next one you get more potentiation, and now you go back to normal. And so the last one is back to normal again. So that's what we call train of 4 with potentiation. Does that make sense? Did I lose anybody? If you understand this, you'll be really far ahead in clinical. Yes?
And this is
post-tetanic potentiation.
This is normal?
This is normal. This is normal. Okay? Now, let's take a look at what happens when you use different agents. If you're fully depolarized, let's say I give you a full dose of succinylcholine. I give you enough succinylcholine that you basically bind to every single receptor. Okay, so here's my little drugs. Drugs going to come in purple, I think is the color. So here's the drugs in purple. Boom, they come in. That's succinylcholine. Now it's bound to every single site. So even though I'm sending a twitch to the nerve, it still releases acetylcholine, but it's got nowhere to go to bind. So I get 0 twitches. Okay? So that individual has 0 twitch response. So that person is fully depolarized. Now the next time, I'm going to give this individual a 90% competitive block. Okay, so if you look at the numbers, I've got 10 receptors, and I've only left 1 receptor open. That's a 90% block. Okay? So in this individual now, when I give the stimulus, okay, when I give the train of 4, I should expect the actual response to be small. And it should be only 25% of the normal twitch height, because you're not getting the normal twitch height to get 100%, say 4 bindings. Now you're going to get only 1. So what you're going to get is the following. 1 twitch, only 4 molecules still come out, but only 1 binds. Again, the same thing happens again. Binds once, binds once, and binds once again. So this basically is demonstrating to you that this is a non-competitive action. Okay? It can only bind to 1 receptor, and it's only going to give you a small twitch. There's no fade. You notice that there's absolutely no fade in these individuals. Okay? Now, if you have 80%, now you're left with 2. Now you'll see the twitch height will be elevated by 2 bars, up to 50% height, and it'll do it every time again. So what depolarizing agents do, because they're non-competitive, you can't push them off. They only give you what the number of receptors that you have available. So these people do not have fade at all. Okay? 70% block. Now you're going to get 75%. Okay? And then once you get below 60%, then you're going to get full strength. So even somebody who has 70% block on board, you can't tell that they still have 60% of those receptor sites are blocked. And that's really dangerous if you think about that. Okay? You can actually be walking around with 60% of your sites blocked, and you still would have what would appear to be normal function. Okay, as long as you're not doing anything strenuous. Okay? Now, if you have 80% blockade, your post-tetanic count, and so we can do it in phase 1, there's no competition. Okay, so here's what happens. I'm going to give tetanus. Tetanus is going to mean that you're overwhelming the site again with acetylcholine, but because succinylcholine is non-competitive, it doesn't care. Okay, so as a consequence, you'll see what happens. You get your tetanus. Now you get massive release of acetylcholine, but now you get no post-tetanic potentiation at all. It doesn't care. You can't change that you only have 2 receptors that are available. This is an 80% blockade. So when you give somebody succinylcholine in a phase 1 block, you should see absolutely no fade at all. Okay? All right, so now let's go on to the next part. So here's what you end up seeing in the textbooks. So the textbooks will give you this kind of thing. They'll give you the depolarization blocks. In phase 1, you'll get train of 4, which is diminished, but has no fade at all. Okay, there's no fade in double burst stimulation, and there's no post-tetanic potentiation after the dosing with a normal phase 1 blockade. Okay. Does that make sense now? I hope so, because that took me about 80 hours of work. Okay? Animation is crazy. I'll show you the slide one day. It's like 82 points of change every time you make one of these slides. So it's kind of ridiculous, but it's kind of fun. It kind of makes it more sense to most people. All right, now let's go into phase 2, then I'll stop, and I'll give you guys a little break because I want to talk about phase 2, and then we'll talk about the next agents. Phase 2 mechanisms have prolonged exposure to the neuromuscular junction to succinyl can result in desensitization block or a phase 2 block. The other thing where this can take place is if you have atypical plasma cholinesterases, then the phase 2 block almost develops immediately. And if you give a single huge dose, which is a 3 milligram per kilo dose, which is what we do in the day surgery centers, we induce a phase 2 block immediately. Okay, we want a phase 2 block, okay, because it's so rapid in onset that doesn't cause myotonia, okay, which causes pain post-op. Okay, but what you see is it changes the characteristics of the drug. The drug no longer acts as a normal agent, but now acts more like a non-depolarizing agent. Okay, and the inhalational agents actually accelerate the onset of phase 2 blockade as well. The anticholinesterase drugs can be used to antagonize it, but the response is difficult to predict, therefore it's advisable to allow spontaneous recovery. I am not a fan of allowing somebody to try to reverse with anticholinesterase drugs in a phase 2 block. I think you're asking for trouble. I've seen people try it, and does it work? Yeah, I've seen it work one time, and then I saw it fail 9 times out of 10. I didn't like the 9 times out of 10, so I just wait. Okay? Now, so how do you explain phase 2? You know, how can you explain it? Dr. Nolan, you told me that it's a non-competitive agent. How could it be that it also works and looks like a phase 2 agent? And the answer is that it acts presynaptically. Okay? It not only now is acting postsynaptically, which is its preferential site, but when you give enough of a dose of it, it begins to also bind to presynaptic voltage-gated calcium channels. Kind of cool. Okay? So what it basically does is going to inhibit the release of acetylcholine. Now let's take a look here. These are voltage-gated calcium channels that I've added to your drawing, and that's in yellow. So these yellow guys up here, okay, which we named 1, 2, 3, 4, 5, 6, 7, 8, 9. Okay, those are all voltage-gated ion channels that are presynaptic, and they are assisting me in releasing the actual acetylcholine molecules out of the presynaptic site. Okay, so now what I'm going to do is I'm going to give a really high dose of succinylcholine. So it's coming in, and some of it's blocking preferentially my sites. Okay, but what you're going to see next is when that calcium channel opens, that's when the molecule will bind into it. Only when the calcium channel opens. So it waits for it to open. So these molecules appear to be okay initially, but when they start opening more frequently, you'll see that the actual medication will affect their activity. So what you see when you do a train of 4 on this individual is you get your train of 4 originally, okay? You get release of 4, now you get your typical height. But now look what happened to your voltage. Now instead of releasing 4, now it's releasing 3, now it's down to 2, and the last one's going to only release 1. Okay, so this drug now is acting in the presynaptic sites and inhibiting the release of the actual acetylcholine molecules. And that's what quantitatively gives you this fade effect. Okay? And that's why you can reverse it, because if you reverse it, you can see that down here, the number of counts that you have is lower, so you can reverse this. But it's kind of tricky. It's one of those things that acetylcholine now is going to begin to accumulate in the middle, and that's why it can actually work. If you look at post-tetanic non-competitive blockade, okay, when you give tetanus for an individual with this, you'll do your tetanus, you get a massive outflow, the maximum is 4, but then the next one you have is now down to 3, so you're going to get immediately, you're going to get fade even with your tetanus. So in tetanus, you're going to get a fade, and you're not getting release. So the next one you do your train of 4 following this, it's going to give you a diminished train of 4 than you expect. See, with fade. Okay? So that's how it works. All right, so what you see is in depolarizing agents, you get fade with your phase 2 blockade. You get fade with double burst. And you get fade in your tetanus as well as in your train of 4. Okay. Pavilon will also bind to some muscarinic sites, which is why it also increases heart rate. Okay. All right. So I'm only going to get to about another 30 more slides out of this, and this got like 120 slides or 106 slides in it, so we've got next week to finish it up. The non-depolarizing agents, on the other hand, work as competitive antagonists of the nicotinic sites. So in essence, if you have enough acetylcholine, you can begin to overwhelm it and begin to push it off. Okay? The chemical families you have is benzols and the aminosteroidals. All the benzoisoquinolones may cause some form of histamine release versus aminosteroidals don't. These non-depolarizing agents are basically quaternary ammoniums. Because of quaternary ammoniums, they do not cross the blood-brain barrier. Acidic conditions actually protonate the quaternary ammonium, increasing its potency. So that's why when you're asked, like, why is it that when a person is becoming acidotic, it's more difficult to reverse, it's because the neuromuscular blocker is actually made more potent by acidity. It's becoming more protonated. The bisquaternary is more potent than monoquaternary, which in some agents you'll show you that. We'd already showed you that before. They bind to the acetylcholine receptors post-junctional, and they also bind to pre-junctional sites as well. And they also inhibit the calcium channels when they're open if you give enough of the dose. The benzoisoquinolones you can see here. There's mono, there's bi-quaternary compounds. Atracurium and doxycurium are bi-quaternary compounds. All the benzoisoquinolones have acurium in it. The bridging structure is important for the potency, and they are a little bit lipophilic. The aminosteroidals have a steroid structure in the main structure of it. They all have uronium in as part of their name on it. They can be long-acting like Pavilon, pancuronium, or pipocuronium, or intermediate-acting like becuronium or rocuronium. Now, let me back up. The aminosteroidals are long-acting. Pancuronium, it will cause mast cell degranulation and causes the vasolytic properties, which causes the heart rate to increase when you give Pavilon. Becuronium, on the other hand, doesn't really have any cardiac effects or histamine effects. So the downside to it is a little bit more expensive than the generics, a lot cheaper, so it's not much of a problem. And then rocuronium is intermediate acting. The downside of rocuronium, it tends to be a little bit more unpredictable when redosing. All right, so let's take a look at the first, the non-depolarizer agents. Okay, in this case, we've dosed this patient now for the non-depolarizer, so that have 100% blockade. Okay. What you'll see is when you give this person a train of 4, which is what we're going to do next, is you can see the acetylcholine release, and it's going to try to competitively try to push off the molecule. So we give one dose. Okay, the first time it doesn't really do anything, so you get no response. It's so receptor bound that it doesn't make a difference. But you can see that there's enough molecules that it's also inhibiting the synaptic site, so it's actually diminishing the site. But you're not seeing the fade because there's no effect. So it appears that you have just no twitches at all. As you go down to 90% blockade, now you'll be able to bind to one, and you'll actually be able to push off one, so you get a 50%. But now you're getting inhibition presynaptically, so you're also releasing the quanta so it can't compete, and then you get the fade effect that you see with non-depolarizers. Does that make sense? So it's a dual effect when you're giving non-depolarizers. It's affecting both the postsynaptic as well as the presynaptic receptors when they open up. Now, if you're 80% blocked, now you're able to push off some molecules. You get a nice twitch height. Now you're going back. You still see fade. Okay? But this person is still 80% blocked, and you're seeing fade still out of it. Okay? Now, as the molecule number begins to drop off, and they're out of the extra junction, they're inside the synaptic cleft, and you can see these are the molecules of the medication here. As they drop off to low enough levels, now you're not going to have as much pre-synaptic inhibition. Okay, so you're going to begin to see less and less fade as a consequence. Does that mean that you still have the post-junctional receptors not blocked? The answer is no. Let's take a look. Next one is 70%. Okay? But now there's hardly enough left to really cause a lot of post-junctional. So you're starting to see less and less fade effect. Still have some, but it's hardly noticeable. And if you, at this point, if you actually look at it, you can't tell. If you do a train of 4 on somebody, you will not be able to figure out that the person has fade. You will see it almost as all the same twitch height. So you will assume at that point that that person is perfectly okay and it doesn't need a reversal. And in actuality, that person still has 70% blockade. And you can be in a lot of trouble. If you look at 60 to 70%, okay, now you have no more prejunctional effects at all. Okay, this is a train of 4. Gives you equal height each time. Okay, but you still remain at 60 to 70% blockade. You literally cannot see the fade. Now, what about post-tetanic potentiation? What happens when you compete? Well, if you give enough acetylcholine in here, you're going to be able to compete and push it off. Okay, so if I give tetanus to this individual, let's give a huge tetanus dose, then what should happen next when I get the effect is that, oops, come on, don't mess up. There it goes. Okay, you're going to get 4 releases. Okay, now you have extra around, but you're going to get fade effects over time as the next dose comes out. Okay, it's a little slow. Okay, but it still gives you that fade effect. Okay, so when you're giving tetanus to a person who has a competitive blockade, you will get fade in the actual tetanus component. Let's finish it up here. There you go. The last one, because it's still affecting the post-tetanic stimulation, it gives you that effect. Now, when you do your train of 4 out of it next, you're going to see potentiation because you still see acetylcholine molecules there, so you get a potentiated effect. See, it pushes off the drug. So you're going to get a higher than expected response. But then the next one you're going to see is that you're going to release, because you're going to start affecting the quanta release, you're going to see a diminishment, so you're going to still see a positive effect, but it's diminishing. It's causing the fade effect. Again, the fade effect is from the prejunctional inhibition of the drug. So that's how you have to think about it. If you start inhibiting the presynaptics, it starts causing fade. All right? Now, what else can bind to these presynaptic receptors? And the answer is acetylcholine in high enough levels will start mimicking this effect as well. Okay? All right, so now let's look at post-tetanic potentiation with competitive blockade, 90% blockade. This is going to be still show fade. To speed this thing up. It's going a little too slow. Goes in, pushes off one molecule, so you're going to get eventually a tetanus that's showing significant amount of fade. You know, you're still getting a lot of presynaptic inhibition. You're still releasing quanta that's coming out, but it's still inhibiting
the presynaptic, so you're getting less and less quanta. And eventually, when you finish up this duration of time, which is continuous, you're still going to have some residual acetylcholine molecules left out there that are not quite coming across and binding to the receptors. So when this individual goes to the next step, which is the train of 4, here we go next to train of 4, you're going to get an accentuated response. You've got these extra acetylcholine molecules now released, okay, now competitively pushes off, so you can get a hyper-stimulated response, okay, compared to tetanus, and then you're going to get a fade effect after that. Okay, so every twitch you have after that should show fade. So a 90% blockade, you'll see more and more fade, okay? It's so much fade that you're only down to 2 twitches. The purpose of using tetanus for using post-tetanic potentiation is to know how deep the blockade is. If you want to have somebody with no twitches at all, no possibility that the person's going to cough, nothing, okay, then what you want to do is you want to do a train of 4 and you want to be at 0, but then you want to do a post-potentiation stimulus, which is you give the tetanus, and then have 1 to 2 twitches. That person is intensely blocked. That person's not going to move, not going to cough, not going to do anything. Okay? If you do it this way, the danger of it is that if you give a tetanus and you see 2 trains, it doesn't mean you can reverse. This just means that you have 90% blockade. And it actually will mean if you're using vecuronium, it'll take 45 minutes before you see 1 twitch without post-tetanic potentiation. So you're 45 minutes away from even considering trying to reverse. If you use atracurium, it's going to be a little bit less. It's around 30 minutes. So the only time you use post-tetanic potentiation is to make sure that you have a very, very, very deep block. Most of the time you should be using DBS, which is double burst stimulation, which is easier to see, or train of 4. Double burst is really used to cause very intense blockades. Okay, so this is your no drug in the side, and then you see your non-depolarizing agent showing the fade and the post-tetanic potentiation. So if you look at these, when you get confused, come back, read the chapter, then go back and look at these animations. It really makes it more clear to you what's going on. Okay, because a lot of people just sort of write about this stuff and they just sort of make you memorize it. I don't like memorizing it because it doesn't make sense to me. So I try to do it visually to see what is the drug really doing, and that makes more sense to me. So when people tell me, well, you know, if you give an anticholinesterase agent, you can muscle relax that individual, and the answer is yes. If you give it an inappropriate high dose to somebody, you will then increase your acetylcholine molecules in the junction. So much so that now they're acting as presynaptic inhibitors, and that will cause the same kind of effect. It will cause fade. So fade should be in the back of your mind as prejunctional effects. Just loss of twitches would be just normal post-junctional effects. So when you look at non-depolarizing agents, when you're giving it under normal circumstances for the effect that you want, you're having dual effects. Succinylcholine can be actually broken up into 2 drugs. You give it in a low dose, it acts just only post-junctional. Give it high dose, it acts post-junctional and prejunctional. Okay? You keep that in your mind, it makes more sense. As soon as you add the prejunctional, you get fade out of it immediately. So volatile anesthetics also potentiate neuromuscular blockade. Halothane will do that, isoflurane will do that. All of them depress the train of 4. Possible mechanism by the volatile anesthetics is they decrease sodium channels, they decrease voltage to the nerve endings, and they decrease the voltage gate calcium opening, and as a consequence, decrease the release of neurotransmitters. So you can see you don't see phase 2 blockade with a volatile agent. You just get more of like a phase 1 kind of reaction. You get just decreasing in height, but it does decrease it. Now here's what you use. This is our neuromuscular blocker monitor, which is a peripheral nerve stimulator. And the peripheral nerve stimulators come in different companies and different sizes and different things. These are the very basic ones here. And they have a single twitch, which is pretty much useless. Instead we use what's called train of 4, which is 4 equal stimuluses. And then you have double burst, which is easier for visualization. Trainer 4 was used for initial studies because they're actually using myograms, okay? But we're stuck with them and sort of use them now in clinical. But really what's actually more effective is looking at double burst, because you can tend to see the difference between 2 twitch heights more better than 4. And then you have pulse-tonic stimulation. And then you have, what you should look for most of the time is when you're working with non-depolarizing agents, you should have 2 twitches and that's it. That's what you want. You shouldn't be at 0, and at 1 you're a little too deep. At 2 is where you should be. At 4 you're not adequately muscle relaxed. The person's going to possibly move for the surgeon and cause a problem if you're trying to have that for some reason. But a lot of anesthetics don't need muscle relaxation, as you can see. Yes?
What does it mean to be less than 0 or 1? Does it mean it's going to take longer for everything to...
What a trainer 4 of 2 basically means that you see 2 twitches out of 4. Okay, so when you see the person, when you twitch them, you get 1, 2, and then you will see nothing. Okay, that's a twitch. If you see just 1, you'll just see 1 switch, and the next 3 will get nothing. You won't see any movement of the hand at all. Okay, so that's 1 out of 4. If you see that you give stimulus and you get no movement at all, that's 0 out of 4. Super paralyzed, yeah. Yep. And that means that person most likely is 90% blocked. And it's pretty intense. Okay. Placement of electrodes is always put red closest to the heart. That's how I remember it. Red is where the heart's at. So always the probe should be switched where the red's going towards where the heart's closest to it. Okay, so you put the red here and the black out here. Red here, okay, black out here. Okay, so it's always away from the patient. You can see that the temporal branch of the facial nerve is the one that actually controls your orbicularis or oculi. Okay, it's the temporal branch on top, so you put your red in the bottom here, and then you put your black up top. It tends to reflect laryngeal function, but it overestimates muscle blockade. The diaphragm and other muscles may actually be all back. So that's one of the downsides of this agent. But this is a good way of actually recognizing that your larynx is back. So if you have to check a trainer 4, well, you'll see the trainer 4 will actually occur more rapidly here than here. This shows the block comes in later. Okay? So the diaphragm will be back, muscles will be back, and the surgeon will complain, it's like, I can't see. The patient's moving or the patient's breathing. Yeah, that's right, because this could still be 0, and you could have 1 twitch down the diaphragm, and my diaphragm might start moving. That's why you might have to do post-tetanic potentiation to get that person really deep if you need that situation to take place. The adductor pollicis, the diaphragm requires 1.4 to 2 times as much neuromuscular blocker as the adductor pollicis muscle, so it also underestimates diaphragmatic paralysis. Okay? And what you're going to see when that thing fires is you're going to see the hand motion like this, and you can see the adductor pollicis is much more sensitive than the diaphragm to the effects. Now, sequence is dependent on the blood supply. In fact, if you give ephedrine to somebody, you actually will increase skeletal blood supply because it's a alpha 2 agent, sorry, beta 2 agent. So it actually will increase blood supply to skeletal muscle. And also, it's more rapid for diaphragm as a consequence. It affects small, rapidly moving muscles like eyes and face more so than anything else. So sensitivity to least sensitive is laryngeal muscles, facial muscles, skeletal muscles, and diaphragm. Return to function reverses in the other direction. Diaphragm comes back first, skeletal muscles come next, facial, and then laryngeal muscles come last. Facial muscle paralysis closely coincides with laryngeal muscles. So that's why we use the orbicularis oculi to really tell us how good the larynx is doing. It shows you when you give atracurium, get a very intense blockade, and then the recovery is much faster with the diaphragm than in comparison to the adductor pollicis. That's what this picture is showing you. This is the onset when you give the dose. This is dosing here. Then you give the medication that it gets effect. It gets very quickly. It doesn't really matter. The diaphragm's a little bit more resistant to it, so it tends to take a little bit more time. But once the reversal takes place, the diaphragm comes back first, and then you have your adductor pollicis comes back last. Okay, so that's important for you to know. Single twitches. This is what it initially is done. If you look at the books, what they're doing is you're doing a single twitch repetitively every 10 seconds. And they put it on a myogram, okay, so you can see it, okay? This is the stimulation, bang, 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 and this is the response that the muscle's getting. When you give the non-depolarizing blocker agent, okay, in the arrow, you start seeing the effect in a few minutes, usually about 1.5 to 2 minutes. So don't think that these drugs are immediate. It takes a few minutes for them to get out to the sites and actually have the effect. I've seen students get kind of nervous because the surgeon's getting started, and they give 20 milligrams of atracurium, and they look up and the surgeon's just about to cut and go, oh, I better give another 10. No, just wait. Give it another 2 minutes. Should have dosed the medication beforehand. You sort of screwed up, but don't add to the screw up by adding more, okay? Because you might find out that you're now intensely blocked and you don't need it, and the surgeon's then done, okay? Versus if you can take them down to 2 twitches, surgeon's happy, you know, you can reverse that person if you need to. The downside to single twitches, it requires control measurements for meaningful interpretation, okay? So it's not used clinically, it's not predictive of the level of neuromuscular blockade. It's kind of pretty to look at because it tells you how fast the recovery time it takes to get back from these agents, but it's really clinically not very useful. So what came up in the 1970s was train of 4, okay? So train of 4 is not something that's been around in anesthesia since the induction of neuromuscular blockers. It's only been around since the 1970s, okay? So what percentage of the people trained out there in the world are trained before 1970? It's about 40%. So about 40% of your practitioners don't know how this thing really works. Okay, they sort of understand it a little bit, but the way you understand it will be very different than somebody even I trained 4 years ago, because things still progress, new recommendations, okay? So a train of 4 is something you really have to understand for forward practices, because I think it's going to make a bigger difference. And there's new things that are coming out, which I'll show you about, which are MMGs and things like that. What you see with train of 4 is you get 4 twitches 0.5 seconds apart. That 0.5 seconds gives plenty of time for the cell to repolarize itself. It also gives plenty of time for acetylcholine to be broken down by the acetylcholinesterase. And basically the actual site should be completely zeroed out of any acetylcholine that should be around. Okay? So you get a new twitch, like it's a new muscle contraction. The first twitch is used as a control for the others, and the degree of paralysis is dependent on the train of 4 ratio. Train of 4s of less than 1 or less is very deep level of neuromuscular blockade. You're looking at 90% blockade or more. You must have at least 2 train of 4 prior to reversal, and never reverse with less than 2 train of 4. Don't do tetanus and then do train of 4 for reversal, because you're basically doing post-tetanic potentiation. And you may actually be very fooled by that. I've seen people do that. They'll do tetanus and then do train of 4, and they'll say, look, doc, I got 2 twitches. And I'm going like, yeah? And they go, what does that mean? It means absolutely nothing. It means you're deeper in heck. Okay? Now, once you did tetanus, what can you do? Can you go back and do train of 4 on that again? You got to wait 5 minutes at the minimum. If you don't wait 5 minutes and you put it again, you might still see 1 or 2 twitches, and you might think you're ready to reverse. And then you do the other side, and you got nothing on the other side. Okay, the other side's telling you the truth. This side's still faking you because it's still post-tetanic. It still has a lot of residual acetylcholine sitting there. So if you want to decide to do reversal, you don't use tetanus. Never. Your decision tree to make a reversal decision should be based only on train of 4 or only on DBS. Okay, never with tetanus first. Okay? So don't do tetanus and then do train of 4 for reversal. Train of 4 ratio is really clinically a poor estimated reversal. It really is, unfortunately, but that's really about the only thing we have right now, except for the new things that we have. I'm trying to put an order for it, and I've actually called the rep 3 times, and he doesn't answer it, so it kind of pees me off, but hopefully I'll get that done sometime this summer. What you do with this is, you can see this is a train of 4 stimulation. This is what you should expect. The first one is a normal individual, so a normal response should be a nice height, twitch height. Okay? For a depolarizing agent, which is in the bottom, you get the same normal twitch height. Then the arrow indicates where you gave the medication. Okay, succinylcholine has been given at the bottom. So in this case, you're basically blocking it non-competitively, so you have no presynaptic effects, And now you're seeing the train of 4, bang, 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 same site. But then you see as the person comes back, the train of 4 becomes higher and higher. And that's a ratio of A to B, which means that there's, for a train of 4 for a depolarizing block, it's always 1. There is no fade. Okay, so the train of 4 for succinylcholine, that's a good test question for trick. They say, what is the train of 4 for succinylcholine? The answer is going to be 1. The first twitch is going to look like the last twitch every time, unless you're in phase 2 blockade. Okay? But if you, on the other hand, using a non-depolarizer, the first twitch is the control that tells you how much paralysis you have with the next twitch. The more profound the paralysis, the more twitch height there is difference between the first and the last twitch. So if you have 0 twitch on the last one, that means 0. Okay? And the first twitch has 1, that's 1 out of 4. Okay? Which is 1/4. Okay? All right. So this is, again, somebody with intense blockade. Moderate surgical blockade should be what you want to have. You should expect, if you give a normal dose of somebody, and say you're inducing them with a non-depolarizing agent, and you decide that you're going to give that person vecuronium initially to get them intubated, you're giving them a very high dose. You're giving them the intubating dose, not the monitoring dose. Okay, so the intubating dose is 3 times the normal amount. Okay, so when you dose them at that point, which is in vecuronium is 0.1 milligrams per kilo, then the response that you should get is a prolonged intense blockade initially for about 35 to 40 minutes. And then you'll start seeing 1 to 2 twitches. What's interesting about this is that during this intense blockade period, if you watch your end-tidal CO2, it'll drop to its lowest point in the case. It usually will drop to 28 or 30 during the case. Most students will make the mistake of taking the ventilation and drop it down. Okay? And the reason they're making the mistake is because what you're doing is you're giving a muscle relaxant that basically inhibits cellular activity. And that CO2 is going to come back to normal here in a little bit, and you've already got your minute ventilation dropped off, and you're going to get hypercarbic, and the person's going to breathe on you, and you get in all sorts of trouble. So if you already intubated them, put them on a normal minute ventilation, sort of live with it, and then watch it, and it's actually a great monitor. As your twitches begin to come back, your metabolic rate increases, and your CO2 begins to climb. So if you see the CO2 is at 30, and all of a sudden it's at 34, it happened because your muscle relaxant is wearing off. And you can detect your twitches, and now you got 2 twitches. Pretty cool. It's a good way of actually monitoring. Okay? And eventually you start seeing recovery, and eventually you get full recovery, which is what you want, which is a train of 4 with no fade at all, which is what you really want. At this point of recovery, you still can have up to 70% blockade. These train of 4s, these still have 4. There's still fade here, okay? But they're all still what? You're still getting 4 out of 4, but with fade. You could still be down here and still get 4 out of 4. That person's more intensely blocked than this one up here. Yes?
If you had a significant difference between the first and the second twitch, a really big one, would you wait to reverse, or would you get comfortable reversing that?
As long as I saw 2 twitches that I saw was reliable on 2 sides, then I would reverse. Full reverse. Then I would trust my reversal agent, which is anticholinesterase agent, to reverse the effects. It'll take 7 to 11 minutes for neostigmine to take place, and that's what I have to be patient with. Now, mark 7 minutes or 11 minutes. That is an eternity in the operating room. Especially, we can't be delayed. A surgeon takes an extra 30 minutes because he needs to put an extra stitch in. Nobody complains. Okay? I've never had anybody look at a surgeon and say, geez, what's taking you so long? Can't you sew? I've never had anybody say that to a surgeon. But everybody looks at us anesthesia. Says, can't you just shut off your agent? It's like a light switch back there. Why don't you just shut off your little agent? Shut off the gas. Yeah, I wish it was that simple. It takes years of understanding the pharmacology of this stuff to really make it effective. And trust me, all of you are going to get burned. Every single one of you is going to make a screw up when you're using this stuff. Because until you get really comfortable with the drugs, you're going to make little mistakes. Now, will they be bad effects? No. It just means that you're delayed. Even I make those kind of mistakes even after 20 years experience. Okay? But what's really cool is I can extubate most people in under 30 seconds when the surgeon's finished. When the last staple goes in, my target is 30 seconds after the last staple is in, the patient's awake and extubated. That's my target every time. That's my standard. Your standard will be 10 minutes. Okay? So I hold you to a little bit different standard. Okay? But by the time you're a senior, I will expect you to be down to 3 minutes. And I work with you, and you learn from what I teach you, you will be down to 30 seconds sometimes. And about 90% of the time, you'll be around 30 minutes, and about 10 times out of 100, you'll be at, or 20 times out of 100, you'll be at 30 seconds. And I'm consistently at 30 seconds every time, because I'm watching certain things that I have to keep explaining to you over and over again. The good thing is I've given you already the pre-lecture, so that helps you. But you got to put all this stuff together. It's complex, and it's going fast, and you got to know it's a little bit of an art. You got to know when to shut it off. Okay? But the thing is, you got to trust that your medications will break down and wear off. Does it always work? No. No, I've been burned. I've had people move a little bit before the surgeon's completely finished, and they'll go, well, you know, the guy's, I need him to be asleep a little longer. And I usually say, staple a little faster. So, and they go look at me like, okay, you know. And then they realize, you know, I'm trying to move them along. You know, and they'll move faster. And then they'll be done. They're not going to remember anything. When you extubate a patient, what do they look like to you? Have you seen that yet? They look like they have this blank stare to them. You could talk to them, they talk back to you. You could have a meaningful conversation with them, and they will answer you with, you know, a dribble. Okay? They don't know where they're at. They don't know who they are. They don't even know what they exist. Okay? So their chance of having a recollection of memory of anything is zero. Okay? I've never had somebody tell me, oh, I remember that endotracheal tube being pulled. Yeah. You know what that, when they usually say that they remember the endotracheal tube being pulled, it's the NG tube that was being pulled in the recovery room. Okay, that's what they remember. Okay? So it takes about 30 minutes to come out of it, even after we appear to be awake and reversed and stuff like that. So people don't, you know, do you have to come out of it? It takes a while for this medication to come off. So what do the train of 4 values mean to you? We're almost done here. These train of 4 values, a percentage of block. If you got 0 out of 4, you got 100% block. 1 out of 4, it's 90% block. 2 out of 4, it's 85% block. 3 out of 4, it's 80. And 4 out of 4, it's still 75% block or less. Well, that's terrible. That means that I'm waking people up, and if I don't reverse them, because if somebody tells you, well, you know, I have 4 out of 4, I don't need to reverse. And my answer to that is, you're insane. You're 70% blocked, at the minimum possibly, or it could be worse. Okay? So be careful. If you do that, make that statement, then you need to go to the next step and do a quantitative analysis, which is what we're going to talk about next week, which is the MMGs. Okay? We'll stop there for today.